we'll post this meeting on our website for future use. And I'll give you the format real quick, as I'll give you a couple of minutes on what VPCa is doing right now and what is coming up next week or next month. And then I think we're missing Sarah Gilbert on this one, so we'll pass up. The real deal is we're just waiting for HR 4880 to be voted upon in our Congress, and that is in the hands of Miss Pelosi. And as soon as she decides it can come to the floor, it'll get voted on, and hopefully it'll pass. There's not been any objection to it at all. It's also waiting in the Senate. The Senate's waiting to see if the House passes it without any modifications, and that's being monitored by Senators Moran and Senator Tester. So we'll see how that goes. From VPCa perspective, we're going to announce some new officers coming up in about a month or so. We're going to announce that Tony Minter is going to become the executive director of the company, or of the nonprofit, and Chris Proven is going to take over director of exhibits and outreach. And so we're actually growing a little bit. We've got a lot of things to do. We've now realized that we got to step up the pace quite a bit on some of these things, and increase the outreach and what's happening. So next week we will be in two places. One at ASTRO, the American Society of Radiation Oncologists, in San Antonio. That's the last week of the month. And we'll be at AUSA in Washington, D.C., which is the Army USA show, where we'll just be handing out materials and raising awareness. It's a big show in Washington, D.C., where all the defense contractors go. And about 90% of those people in attendance are all veterans. And so they're also right in the target zone for knowing about prostate cancer and making sure that they get screened. So the last time the show was held, they had over 70,000 people in attendance over a 3-day period of time. So we expect probably to see about the same in downtown DC. So it's attended by a lot of congressional, Department of Defense, and really in all branches, but Army primarily, but a lot of the other branches will come over as well. So that's about it for us and for the Hill. I'm going to now turn it over to Dr. Lora Wilson from Pfizer. She is the GU field director for Pfizer, and has volunteered to talk to us this evening about the details around, or some new considerations around shared decision making, and also some maybe some aspects of clinical trials and how to and where we can go with that. And I see that Terry's got his audience in line there, so we're ready to go, Lora.
Thank you so much. Thank you for the introduction. I am humbled to be here with you today, and I appreciate your attention. I am Lora Wilson, Field Medical Director with Pfizer, supporting Pfizer's genitourinary therapies, which covers prostate, kidney, and bladder cancers. But my connection with you today is more than just being a field medical director supporting RGU therapies. My father was diagnosed with prostate cancer. I have two brothers, and they both have been diagnosed with prostate cancer, and one prostate cancer and kidney cancer, as well as my grandfather. So, 4 of my closest male relatives have all been impacted by prostate cancer. Fortunately, for my father, my brothers, was diagnosed early, and they're doing well. My father is 89, so you can imagine how old my grandfather would be if he were still alive. His prostate cancer spread, and he passed away, but he was elderly, and screenings were not what they are today. And I'm from Jackson, Mississippi, so it was even different back in Mississippi for a grandfather that would be, well over 100. So I come to you with heart open, and knowing that though I'm female, I am affected too. So thank you for having me. I'm going to share my screen now. Just 1 second, it's coming. I work with multiple screens, and it's always important that I share the right screen.
Let me know if I need to make you the host, Laura. Oh, there it goes.
Okay. So you're seeing just shared decision making. That's all, right?
Yes.
That slide. Okay, perfect. Sometimes you can see other slides, or I have 3 screens that I work with, so I have to be careful. Okay, so today in the discussion on shared decision making, I just want to provide an overview that shared decision making, the emphasis is making sure you feel like you are part of the decision making process, and that you're asking the right questions and knowing that any question is the right question. So the key is make sure you're asking questions. And I'll just provide some examples of the type of questions that could be relevant for you. You want to make sure that you know that there are more than one treatment options. You know, that you're asking your healthcare provider about options to therapies. Understanding there's different patients may take different choices based on what's important to them. And so you elaborating on what's important to you will be key on the type of choices that you can make. Whether you want surgery or radiation for early prostate cancer. What treatments, there are many treatments that are in advanced prostate cancer. Having that type of conversation, what are the options? Maintaining quality of life. If that's your focus, making sure that you're leading with that. And that will help define what type of treatment options that you may want. If you want to continue to work, that's another example. Or the importance of a specific event. Maybe therapy can be tailored to different lifestyle events or lifestyle choices that you want to make in the near future. So keeping those in mind as you address your treatment options, because we've come such a long way from when my grandfather was diagnosed to today. We have many more options, and knowing that there are options throughout the continuum of this type of disease is very important. Sorry, I skipped ahead. Okay, knowing that there's not just a single right decision. If you are taking androgen deprivation therapy, you may want to have a discussion whether you want to feel like you have more control and you have an oral therapy, or if you'd like to just get it done and then not think about it, an injection may be the right move for you. When you're looking at novel hormonal therapies, you know, when you're having that discussion, just a different type of therapy for advanced prostate cancer, asking your healthcare provider about the adverse event profile differences in those and matching that with what type of lifestyle you have or what goals you have are really important. So it's all important to be prepared when you're talking to your doctor and having questions about how can I prepare myself for this next appointment. It's very important to know what is sound scientific information and where you can receive it. And your healthcare provider, the advanced practitioners, and other healthcare providers in the office can help provide you with those resources. Recognizing the decision needs to be made, and you must be informed about the best way to make that decision with your doctor. Understanding your pros and cons of your options. Having the information needed to evaluate your options. And how can you do that research at home? And how can you be prepared to have those discussions? The desired decision-making process may not always look the same and may be dependent upon your doctor or your healthcare provider. So it's always helpful to bring a companion or caregiver with you to those appointments. They can hear things that you may miss. They may have questions that are helpful that you may not think of. Speak up. Make sure that you're part of the process and advocating for your preferences. Discuss treatment options, risk, and benefits. Discuss your values, what's most important to you, and ask questions. Decide on a treatment plan with your doctor. And it's very important to always, keep your doctor informed of all different types of therapies you may be considering, even if you're looking at other second opinions, I would say. Resources and shared decision making. Well, this is a conversation that you can have with the healthcare provider and other people at the office. Where can you go to get print materials? What are reliable, scientifically sound online sites that you can trust? And what videos are available? All of these can offer structure and guidance in your decisions and providing information related to prostate cancer, treatment options, benefits, and other evidence-based information. Helping you explain the value that you place on your different health outcomes is very important to make sure you keep communicating. And if you find you have a healthcare provider that may not, a medical oncologist or urologist that doesn't have time, maybe there are others in the office that can continue the conversation. Nurses, nurse practitioners, physician assistants, or navigators. These are other questions you can ask. Who else can you continue this dialogue with if they're short on time, and where you can go? Because information is definitely key. And so as you're asking questions about, is this the right therapy for me? What are the other options to this therapy? How long would I be on this therapy? Is there a way, if I'm experiencing adverse events, to have intermittent therapy? You're having those discussions. You also should consider making sure, if the doctor, your healthcare provider, didn't bring it up, that you ask about genetic testing. Genetic testing is looking for DNA changes or inherited mutations in your genes that may contribute to your cancer or may identify if your cancer is high risk. This is another conversation you should have, that you should be informed about. Making treatment, because this can help you make treatment or screening decisions. You can understand your risk for this cancer, the type of cancer you have being more aggressive, or understanding your risk of your family members having the same cancer. As I spoke of earlier, I have 4 males, immediate males, all have suffered or are suffering from prostate cancer. Some limitations include that not everyone is a candidate for testing. It may not be covered by insurance, or it may not really provide a definitive answer, but it is a conversation that could be good to have with your healthcare provider. There are different types of genetic testing. Single gene testing looks for specific mutation. Multiple gene testing look for several mutations at the same time as part of a single test. An example of this is BRCA testing. The BRCA1 and BRCA2 are examples of genes that can be checked for inherited mutations linked to prostate cancer. It's also linked to breast cancer, ovarian, and pancreatic cancer. So doing genetic testing can also tell you what therapy options may be beneficial. Most of us are probably familiar with androgen deprivation therapy used to help treat prostate cancer. Novel hormonal therapies are added on as it's more advanced. And then there are what we call PARP inhibitors. And those are new therapies that are out that are specific for different genetic mutations. So having a conversation about genetic testing, getting those results could open up an array of new treatment options. A genetic counselor can be useful to help decide if you need genetic testing and help you interpret your results. So, and genetic testing could be used if you recommend, or they may recommend, that your family get tested. And it helps put things in perspective, because it's not always a yes or no. It could be an increased risk, but that interpretation can be done with the help of a genetic counselor. And then some reasons to share the information with your family Inherited gene mutations affect multiple generations of families. Your relatives may not be aware of the family's medical history. Genetic insights could help inform some of those missing gaps. Blood relatives, even distant ones, may share the same mutation, and that's good to know. Your relatives may not be aware of the genetic testing for cancer even exists. So as you get more information, sharing that with your family could be helpful. And this next slide is just providing resources for more information regarding markers for prostate cancer and genetic testing and mutations. So feel free to explore any of those sites. Another topic that can come up when you're thinking about shared decision making, the conversation you're having with your healthcare provider regarding your prostate cancer, are clinical trials, knowing that they're available and how they can be useful for you. A clinical trial involves the research using human volunteers and is intended to increase medical knowledge. The study of a new compound, an investigational agent, starts first with preclinical testing. And that you'll see on the left side of the screen in the orange. This is the testing that's done at the bench in a laboratory, and then it moves into animal testing. Once there is a significant amount of information that says it could be useful in humans, then an investigational new drug application is filed with a health authority. In the US, it's the FDA, and this drug moves into a phase 1 of a clinical trial. This is the part now where humans are involved, and at the phase 1 in a phase 1 clinical trial. This is a drug that is the first time it's being used in humans, and the focus is on safety. They're looking for a maximum tolerated dose, but they're also looking at adverse event profile and how safe it's going to be in patients. Patients that are in phase 1 clinical trials have exhausted all other cancer therapies. And this description of these phases is for oncology. It's specific to oncology. Phase 1 trials, patients have exhausted all other standard of care options. And so then it has been allowed for them to use an investigational agent. Once a maximum tolerated dose has been identified and the safety signal, meaning the adverse event profile, has been deemed acceptable, is moved into a phase 2. Now, this is where we're actually looking to see if this drug has efficacy. And efficacy is a term used that if it works, if it's shrinking tumors, if it's doing what we think it's supposed to be doing, reducing a cancer burden. If we see a signal and we see efficacy, positive results, meaning it's reduced, it has increased progression-free survival or whatever the endpoint is for the trial, we move into a phase 3. The focus of a phase 3 is now accumulating data for a large amount of patients, around 1,000 possibly, to see if there's a difference between whatever standard of care is and this new investigational agent. What I want you to be aware of is that at any time, if you're in an oncology trial, you will always have at least standard of care or the investigational agent in a phase 2 or phase 3 trial. You're never given a placebo where you're not having any therapy if your disease would normally be treated with a therapy. So that's important to know how patients are kept safe in these trials. Then after phase 3, if there are positive results and it will be submitted to the FDA, that's a new drug application. And then trials will continue even after that. Post-marketing, it's what we call those trials, post-marketing trials, to look for even more data. So that's an overview of what a clinical trial is, but just know that at all times, patient safety, patients being protected, patients as a priority is the focus. Clinical trials are governed by the highest ethical and legal standards similar to a medical practice. At any time, it's not considered that patients are just guinea pigs or researched on. Clinical trials go through several different review boards, and those review boards are consisted of people that are scientists, medical doctors, as well as community members. Those are lay people that must also evaluate the trial to see if the risk is worth the benefits. Participation is voluntary, and patients can stop at any time. Before trials are started with a patient, patients must give their informed consent. And to do that, they go over alternatives to the therapy, benefits of the therapy, potential risks of the therapy. And the one risk is that it may not be as effective as what standard of care is, and the nature of the treatment. What would the therapy be? And then they answer any questions. So it's also important to note that at any point, you can decide you want to participate in the trial. You can decide you don't. At any time, your consent can be revoked. So it's up to you. But the key is you can also participating is that you can have the use of a new investigational agent that may be better than what's currently on the market. Clinicaltrials.gov is the definitive source for clinical trial information. At any time, you can go there. It's constantly maintained. For new trials, you can search prostate cancer. You can search by your state. You can search by different clinics to find what clinical trials are currently enrolling patients, will soon be enrolling, or are still recruiting sites. That information is always updated at clinicaltrials.gov. Now, so we know, hopefully you understand a little bit of the benefit of clinical trials, but here's something that's interesting. And this is moving to disparities a little bit, that diverse populations are important, but we don't always see that in clinical trials. This graph is showing you that 36.6% of prostate cancer deaths are from Black men, but only 4.5% of prostate cancer clinical trial participants are Black men. So this is a disparity that is very concerning. The low Black participation in U.S. oncology clinical trials disproportionately is creating a body of knowledge that is not applicable to our general population in the United States. But the disparities are not just with African American men. This chart on the left shows you in the top, those that are dealing with cancer incidence in general, 44% are less than 65. So you'll see this on the chart on the left. So of cancer incidence up to 2013, 44% of those with cancer were under 65. What you also see in the middle column is that under 65 included they were 60% of clinical trial participants. This is a reflection that aging or the older population is also experiencing disparities in clinical trial participation. There are many different factors, but what we're seeing is that clinical trials are disproportionately skewed toward younger people, causing an underrepresentation of older people and making the data-based decisions based on treatment for older people difficult to make. There are several different reasons. We'll see that there are 2 or more comorbidities that can affect enrolling older patients in clinical trials. And there's also a communication challenge. A survey of 70 older people with cancer revealed 47% experience barriers in communicating with their healthcare provider. But the disparities are not just with aging. What we also see is that this is a snapshot of oncology clinical trial participation from up to 2019 of all the the oncology trials, we see that on average, 38% were women. I understand we wouldn't see any women in prostate cancer, but we wouldn't see any men in breast cancer. So we still should see about 50% of women in general for oncology clinical trials. We see that the white population is 73%. The Black population for oncology trials is only 4%, when the African American population in the United States is around 12%. The Asian population was 18%, Hispanic population in clinical trials was 5%, and the US population is around 18%. So we're seeing disparities in race and ethnic groups as well as aging. This summarizes some of the reasons. Are we having culturally appropriate materials when we're engaging with potential patients for clinical trials, and informed consent, and making sure we're having an outreach that's appropriate in minority communities as well as rural communities, making sure that we are offering clinical trials where the patients actually are. And all of this is necessary because we want the body of medical knowledge to be a reflection of the demographics of the United States. It will help us better understand the role of biology in cancer treatment. So the more patients we have, the more understanding we'll have. And the more diverse that population will help us better understand different variations in genes and gene expression. And so that right there is my summary of some aspects to consider in shared decision-making, the options in genetic mutation testing, and a little overview of the importance of clinical trials and the disparities we see. Thank you so much.
Yeah, thank you, Dr. Wilson. It's really, we appreciate it. A couple of things. The presentation that you did in the beginning about the shared decision-making, would there be any interest in possibly producing a single page, sort of a guide that we could distribute out to potential patients to go over when they go to see their doctor? Because I think some guys, by the time we get to this point of making decisions, we're not, I don't think we have all of our faculties and we're not always sure about what we're supposed to be remembering. So I think it might be something for us to consider, making a quick guide that they could use for somebody like that.
I think that's a wonderful idea, and having that guide and making sure that their companion or their friend or caregiver that can go to the appointments with them has access to that as well. Absolutely, that's a great idea.
I think we would.
And Mike, real quick on that,
Yeah.
real quick, we are in Lora, we are working on a series of actually shared decision-making videos. There's going to be 10 animated videos with an accompanying downloadable guide on different aspects related to shared decision-making. So a lot of what Lora talked about, there'll be one on what is shared decision-making for genetic testing, clinical trials. So we'll be sure, they're going through the approval process now, so we'll be sure to share those with you. But great suggestion, so thank you. Okay.
The next is, I was going to mention, have you, Dr. Wilson, have you ever seen a group called Massive Bio? It's an online support group that's clinical trial navigators. And if you haven't seen them, I'm happy to introduce you to them. They're funded by NIH and NCI to actually provide a navigator to help people get through clinicaltrials.gov, because it's not the easiest writing or the most effective writing. So I'm happy to introduce you to that as well.
Thank you. I would appreciate the introduction. Yes.
Yeah.
And
Yes,
I think that sounds like an amazing idea because it is challenging.
Yeah, they're very good at it. They've got some AI that they apply to the actual clinicaltrials.gov to pull it apart as they interview. So it's very good. Questions to anybody else, and then we'll get started with our next guest, Mike Smith. But anybody else questions for Dr. Wilson?
I have a purely personal question about the genetic testing. I'm a first generation. My father died at 63 from heart condition. His father died, I like to say, from lead poisoning at the age of 50. but I got diagnosed at 56, and I was a firefighter in the military. And I know the foam that they had us using, they said, oh, you can even eat it. And
I'm saturated.
yeah, that was really exaggerated, but I know we used to use the foam to shine our cars and everything else. Is there a genetic testing that I should probably try and get from either, I go to the Wright-Patterson Air Force Base in Dayton, and I live pretty close to the Columbus VA. So I have two choices. I want to know what kind of test I should ask them to do.
Oh, yes. I think that you should ask your healthcare provider what they would recommend based on, their relationship with you and your, they'll understand your health a little better and would be able to recommend something. And then they will also know what possibly your insurance would pay for, or what's covered at the VA, if
My
that's where you're
insurance will
going.
cover anything, but
Yeah.
Hey, Ray, we had some interesting, I'll talk to you after this. We had some interesting discussions with some firefighters and chief of fire marshal here in San Diego at Miramar at the air show. I'll share some stuff with you because it's all about PFAS and AFFF and all that kind of stuff. So
all right.
there's some things that are going on, but here in San Diego, there's a couple of doctors that are going after it and looking at some things. So I'll introduce you to those guys. Okay?
All right, thanks.
No problem, as always. Okay.
All right.
Anybody else questions for Dr. Wilson, or we'll go to Mr. Smith and let's hear about some interesting imaging issues.
All right. If there's nothing else, and if something comes up later, feel free to just email Mike. He'll get it to me and I'll get you an answer.
Absolutely. Yeah. Thank you, Dr. Wilson. Really
Thank you.
appreciate
Thank
your
Thank you for
input.
having me.
Yeah. Okay, I'll turn it over to Mike Smith from Blue Earth Diagnostics. Mike.
Awesome. Thank you, Mike, and thank you all for having me. I definitely have a background working as a former technologist and just hearing the stories dealing with prostate cancer. I understand, everything that your group's going through, and it's really important just to kind of get that well-versed understanding of everything within the disease state. And Ray, I'm just down the road from you. I'm in Columbus, Ohio. So
Yeah, I'm in Canal Winchester, so.
Okay, I'm in Blacklick, so.
Oh, yeah, you're very close.
Yep.
All right.
Okay, can you see my screen all right?
Yep, it's great, Mike.
So today we're just going to go, I know you guys have a well understanding of prostate cancer, but we're just going to cover a couple aspects, just getting into a little bit of the background. I'm sure you're aware of the prevalence, incidence, and mortality, but just kind of hitting the highlights so that when you are being that patient advocate, you have the most current material. We'll touch briefly on diagnosis, staging, and biochemical recurrence. And then we'll really get into what's really evolved over the past several years with molecular imaging and therapy for prostate cancer. There's been lots of changes within the field of PET imaging, as well as radioligand therapy. And then I'll just touch on what we're working on here at Blue Earth. So we'll just get into a little bit of the background here. So with prostate cancer, it's the second most common cancer in men, as I'm sure you're well aware of. It's a second leading cause of cancer-related deaths. And approximately 1 of 8 men here in the US, they're going to be diagnosed with prostate cancer at some point in their lifetime. Just this year alone, an estimated 270,000 men will be diagnosed. And that's roughly about 14% of all cancer cases diagnosed this year that are new. Diagnosis is key, but so is knowing the likelihood of recurrence after having initial treatment. And unfortunately for prostate cancer, the likelihood is about 40 to 50%. Long-term survival is impacted by the spread of disease. So that's why imaging and kind of what my team works with is really important, so that you know where the cancer is localized. And then with the patients, you can help have that conversation to determine what's the best treatment outcome. So as far as key risk factors, you know, as men get older, there's a higher risk of getting prostate cancer. When you're younger than 40, not so much of a risk, but the risk increases once gentlemen reach the age of 50. And about 60% of prostate cancer cases are diagnosed in men that are over the age of 65. Like Dr. Wilson said, race is another factor. Prostate cancer is more common in African-American gentlemen, as well as Caribbean men of African ancestry. There's also a greater likelihood of African-American men dying from this disease. So maybe it ties into, you know, just participation in studies and whatnot, as well as some disparity within, you know, the community. Family history also can play a role. If you have a father or siblings with prostate cancer, that more than doubles one's risk of developing the disease. And just like what was mentioned before, genetic testing is kind of a newer thing to kind of see what's going on, and may help with determining, you know, the risk of cancer. Some genetic germline mutations, such as BRCA1 or BRCA2, we've seen this actually impacts breast cancer as well as ovarian cancers. That can also increase the risk of prostate cancer for men. So the next couple slides, we're just going to discuss signs of prostate cancer, as well as how it's typically detected. It's often detected during a routine checkup. The most common way, about 90% of the time, is by doing blood tests called prostate-specific antigen, or PSA. This usually increases as men get older, that PSA level, but a higher than expected rise in that level is definitely concerning. Doctors may also perform a digital rectal exam during checkups, looking for or trying to feel for any kind of lumps, soft spots, or harder spots on the prostate itself that are concerning for disease. Some men may experience symptoms that may indicate the presence of later stage prostate cancer, such as the need to urinate frequently, often at nighttime, difficulty voiding or having continence issues, weak or uninterrupted urine flow, painful urination, sexual dysfunction or painful ejaculation, as well as blood or urine in the semen. Men should talk with their doctors if they're having any such symptoms. So as far as with diagnosing prostate cancer, typically it includes the collection of the patient's medical history, review of their symptoms, a physical examination, as well as one or more of the following tests. So like we said on the previous slide, having a PSA measurement. What's the PSA? It's a protein produced by the prostate gland that is often elevated if prostate cancer is present. A digital rectal exam, this is where the doctor manually feels for any prostate abnormalities, or having a biopsy. Here the physician, they can use either a transrectal ultrasound, which is called a TRUS, or MR to guide the removal of small tissue samples from the prostate gland. These samples then are analyzed under a microscope, and here they're looking for any kind of abnormal cells. The cells should look a certain way, And if they start varying as far as the visual look, this is where there's concern that there is prostate cancer. Staging is also important. It identifies the extent of disease. Localized is where you have a tumor limited to the prostate and it hasn't spread anywhere else. Locally advanced is where the tumor has grown out of the prostate into surrounding tissues such as the seminal vesicles, bladder neck, or the nearby lymph nodes. And then there's metastatic disease. This is where the cancer is spread to either distant lymph nodes or other organs. And here, this is where bone is a typical site for metastatic spread of prostate cancer. As I mentioned on the first slide here, even with all of today's advances, both surgically as well as with radiation therapy, up to 40 to 50% of gentlemen will experience recurrence after this initial therapy. Most will actually experience this biochemical recurrence within 10 years. And of those, a third of those, these men are going to experience recurrence that is going to develop into metastatic disease within 8 years. So, and like we saw, once it becomes metastatic, that's where the survival rate definitely drops significantly. So that's just a quick overview of the disease and really kind of getting the information, what's really needed. And now we're going to focus on imaging, looking at radiopharmaceuticals, as well as the therapeutics that are out there. So it's a very noisy slide here. There's lots of agents that are actually incorporated in the PET field. And we're going to go into a lot of these in more detail. It's highly recommended if you want to have a little bit more background on these drugs to definitely look at the prescribing information for each agent to see additional data as well as the trials that supported their FDA approval. There's also been updates to clinical guidelines, the NCCN, RADAR, which is more of a urologic guideline, as well as ASCO. They've been updating these as more research is performed and data compiled, just because there's now more data with these next-gen imaging agents. So they're just gradually getting caught up with everything coming out right now. F18 fluorodeoxyglucose, or FDG. This is the most common PET radiopharmaceutical used, typically in cardiology, oncology, as well as neurology. It's been approved for a long time, since 1999, and it's readily available from multiple radiopharmacies, and they use a cyclotron to produce this. This F18 isotope, it has what's called a radioactive half-life, and the dose or the injection uses the term activity in millicuries to denote the amount given to the patient. So for F18, the physical half-life is 110 minutes. So that means that a dose's activity would be half of that amount, roughly 2 hours from calibration. So if you've ever had a PET scan and you've had uptake time, you're injected with a certain amount of material, and then as time progresses while you're circulating, that drug actually starts to decay because of the physical properties of the drug. So as far as FDG, it has limited utilization with prostate cancer, as most prostate cancers use non-glucose metabolic pathways. It has a low sensitivity for both regional spread and recurrent disease. Also, uptake in prostate cancer versus benign prostate hyperplasia is similar. So it can be challenging to differentiate disease from inflammatory uptake. As you look at the picture here on the right, FDG has the potential for high urinary bladder activity, which could obscure any kind of uptake that would be happening within that pelvis, or for any kind of local lymph node disease. with 18F sodium fluoride. This was approved in January of 2011. Just like with FDG, it uses that F18, so it still has that same 110-minute half-life. The indication for this drug is for diagnostic PET imaging of bone to define areas of altered osteogenic activity. Basically, that means any kind of altered bone production. This agent is also readily available, although it may be more common in the VA system. Generally, a general nuke whole body bone scan is more commonly used. And with this tracer, it only evaluates bone. So it's not going to highlight the full extent of any kind of metastatic disease in any kind of other organs or structures. You're just going to be looking at are there mets within the bone of the patient? And as you look at the picture there on the right, there's definitely widespread mets within this patient. So, this would, the doctors can take this and potentially figure out what kind of treatment they want to do with this. Most likely systemic therapy. Axemin, it's also known as fluciclovine. This was FDA approved back in May of 2016. Has the same 110-minute half-life, is also readily available. It works differently in the body. It is a synthetic leucine amino acid. So this actually gets taken up through amino acid transporters, primarily ASCT2 and LAT1. And it's upregulated in prostate cancer cells compared to the surrounding normal tissues. Because it's the synthetic amino acid, it can't be incorporated into building proteins. So eventually it's actually excreted out of the prostate cancer cells. And this is why if you've ever had an Axemin scan, you're getting on the camera and having the scans done fairly soon after the injection, just because that material can start washing out of the prostate cancer cells. With imaging here, if you look at the image there on the right, you typically see minimal bladder activity with an Axemin scan. And this is beneficial when you're looking locally, or if there's concern for any kind of uptake within the prostate. As far as the indication for Axemin, it's indicated for PET imaging in men with suspected prostate cancer recurrence based on elevated blood PSA levels following prior treatment. So Axemin is just for the recurrent space. If you look at this, as we call it, a roller coaster image here, the patients, they're diagnosed and have initial treatment. Anytime the patient has a rise in that PSA, after initial treatment or subsequent treatments and failures, any rise in that PSA, that's where Axemin can be used, both in the castrate sensitive as well as the castrate resistant setting. As far as the drug itself, it's very well tolerated. It is a radioactive tracer. So just like all these tracers, because they're radioactive, they actually contribute to the patient's overall long-term cumulative radiation exposure. Adverse reactions, this Axemin is very well tolerated. Most common adverse reactions were injection site pain, redness around the injection site, and having a funny taste in the mouth. As with any imaging tracer or modality, there's always the chance for imaging errors. And that's why we, at Blue Earth, we have a well-versed literature and training website. We try and make sure that the readers and the technologists that perform the scan are current on all the latest data. PSA levels do affect the performance of many of these drugs. As the PSA rises, so do the detection rates. But overall, very well tolerated drug. And if there's any, adverse reactions or anything suspected, we ask that sites actually contact us so we can look further into what's going on. Other drugs that are available, and these are the ones that are just recently approved over the past couple of years. There's gallium 68 PSMA 11. This was initially approved at UCLA and UCSF in December of 2020. The indication is for PET imaging of prostate-specific membrane antigen or PSMA positive lesions in men with suspected METs who are candidates for initial definitive therapy, as well as men with suspected recurrence based on elevated PSA levels. So not only does it cover the recurrent setting, it also covers men that are suspected to have METs in that initial setting. This is one of the key differences here. The isotope being used is gallium 68, which is still a PET tracer. It gives off this annihilation so you can still do imaging, but this actually has a shorter half-life of 68 minutes. The tracer binds to cells that express or overexpress the PSMA glycoprotein. And then looking here at the image there on the right, you can see the typical biodistribution of the agent. From this initial work, the first commercial kit, Illuccix, received FDA approval in December of last year. Just earlier this year in March, a second kit called Locomets received FDA approval. So this kit has a slightly different process for basically making the same radiopharmaceutical end product. The product made at UCLA and UCSF, as well as Illuccix, as well as Locomets, the end product is all the same. The label here is slightly different for Locomets. Here we see that the indication includes selection of patients with metastatic prostate cancer whom lutetium-177 vipivotivide tetraxetan, or more commonly known as Pluvicto, PSMA-directed therapy is indicated. So Locomets, on their label, it has that this can be a tool used for patient selection so that you can use Pluvicto. Polarify, or piflufolastat F18, was FDA approved in May of last year. It is, like most of the other tracers, it has F18 attached. So again, that 110-minute half-life, same PSMA mechanism of action. The indication is also the same to that of gallium PSMA 11, as well as that from UCLA and UCSF, as well as that with Illuccix. If you look at the image here on the right, we see normal biodistribution, so salivary gland uptake, liver, kidneys, but you also see this metastatic spread of disease throughout this patient. So normal biodistribution, but this patient definitely has metastatic disease. So lots of changes going on within the imaging field here. Before we touch on therapeutics, just kind of wanted to go into a couple areas that are of interest within the imaging community. So hormone therapy is an interesting topic. There's been several committees meeting. The SNMMI, the Society of Nuclear Medicine and Molecular Imaging, had a meeting looking at appropriate use criteria to see, is there consensus? As far as hormone therapy, there's concern that it actually, it may have an effect as far as with PSMA expression. So currently there's no real consensus. There's concern that PSMA expression may either cause, hormone therapy may cause a flaring phenomenon, or you could be missing some uptake just because of the duration that the patient's been on hormone therapy. And this is where there's actually been recent publications with Axemin where this may be a tool. Axemin has not shown any kind of impact with hormone therapy. But again, there's still no consensus within this, so this is an area to look at. PSMA expression is another concern. As the patients have more thrown at them, more treatments, the disease becomes more heterogeneous. So that expression of PSMA can vary. So you may not be seeing the full extent of disease. As more things are thrown, the cancer may start finding new ways to basically grow and divide. And that's where if they find another pathway, that PSMA expression may be something that's not being utilized. And this may be another area where other tracers could be utilized. Also, another area of interest is oligometastatic disease and using metastatic directed therapy. Like Dr. Wilson said, there's lots of trials going on. There's some trials that are looking at a targeted approach to see if by targeting disease, if this is going to have better impact. Lastly, just wanted to talk about radioligand therapy, Pluvicto. I'm not going to stumble over that name, it's a mouthful. But as far as this, it was approved earlier this year. Its indication is for treatment of adult patients with PSMA positive metastatic castrate-resistant prostate cancer who have been treated with androgen receptor pathway inhibition, as well as taxane-based chemo. Basically, these patients, they have failed most available treatment options. And how Pluvicto works is that basically upon binding to that PSMA expressing cell, the lutetium, which is it gives off this beta energy, it binds to the cell and delivers radiation to the cancer cells as well as the surrounding cells. This radiation induces DNA damage, typically causing single strand DNA breakage, which can lead to cell death. As I said, this is currently basically for patients that have failed most options. There are current studies that are looking, they're called, I'll just name a couple, PSMA-4 as well as PSMA addition, that are looking at how radioligand therapy can be incorporated earlier in the disease state. So the hormone sensitive, as well as before these patients have had to fail, a chemo or a hormone therapy. So more to come in the near future. As far as pipeline, what Blue Earth is working on, we have our own investigational PSMA. It's called RH PSMA 7.3. RH stands for radiohybrid. So what does this mean? It means that it can be used for both diagnostic as well as therapeutic treatment of prostate cancer. We have completed phase 3 testing in both the initial as well as recurrent setting, and those trials are Spotlight and Lighthouse. And if you go to clinicaltrials.gov, you can look those up. Like I said, because it has that therapeutic capability, we are moving forward with preclinical into phase 1 testing of RH PSMA in that setting. So that's all I have as far as the imaging aspect. Happy to take any questions that you may have.
Yeah, I know that's a, and I'd ask Mr. Smith to give us kind of the AP version of medical imaging or this enhanced imaging. So I appreciate that. Anybody have any questions about this? I know there's probably a ton, but we obviously have the ability to do follow-up calls and that sort of stuff. My first question is, what is your next? I mean, obviously you guys manufacture Axeman. What are we looking at as far as timelines for your next product lines coming out, or can you tell us that?
So right now, like I said, we have finished wrapping up the studies for the investigational drug RH PSMA in both the initial as well as recurrence setting. There are discussions currently with the FDA. So that's kind of where things sit right now. I would, as more data comes out, there is material that has been presented from our Spotlight study, and there's material that will be coming out from our Lighthouse in the initial setting. So definitely more to come next year. So that's kind of what's going on. And then there's just preclinical work going on for our therapeutics. With Axeman, we are looking at other indications. Like it said on that pipeline side,
Yeah.
we're in phase 3 for brain mets. So
What is the, and I heard about this the other day, what is the percentage of patients that you see that aren't PSMA positive, or that they can't use PSMA and that they've got to use another imaging, or that they're not eligible for PSMA?
great question, Mike. So it can vary. There's several publications that have looked at this. Typically, when you have initial prostate cancer, the disease is very homogeneous. So the patient is expressing PSMA, but there's still about a 5 to 10% of the patients that don't express PSMA. As more treatments are, the patients go through, this can definitely change. With the VISION study that helped to get approval for Pluvicto, there are about 20% of the patients that expression actually can, and they give a wide range. It went from anywhere from 25 to 40%, depending on where the patient was. So it's still something that needs to be learned. There's definitely interest as far as, what do you do for these patients? And, what's the best approach? And that's something, if you're having a negative scan, having that discussion with the doctor to see what else is out there. I know from our team, there's been discussions, if someone has had, maybe a negative PSMA scan, doing Axeman, because if they're not expressing, that may be another route where you can find the disease and then get the patient on an appropriate treatment regimen.
Right. So I mean, just to clarify, Axeman is a completely different chemistry interaction than the standard what you're hearing now in the market of PSMA. So that's something that all of us as volunteers or advocates need to understand, that when we're talking PSMA, you're not talking Axeman. There's a different chemistry that's ongoing. There's a different mechanism of action, right? I mean, it's totally different.
Correct. One, you're binding to a receptor site. The other is looking at the amino acids. So definitely, that's really important to know how each one works.
Okay. Joe, question, comment?
Yeah, just a little bit. The PSMA, as well as going into Pluvicto, not so much with Axeman, seems to be, at least currently, limited availability in the VA right now.
Yeah. We have we've helped recently a couple of guys get to the drug. Getting the drug to them is sometimes a challenge, but getting them to the drug we've been able to do. So if you have guys that if you're talking to people, we have just last month we flew some guys, or 2 or 3 months ago we flew guys from Iowa to West LA, and it takes an intra VA referral, and then we picked up the tickets for the guys to get there, for they and their caregiver to get out to West LA to get a Pluvicto infusion or injection. They had since then got the drugs back to Iowa City, as where it was coming from. So if we run into guys in our discussions, anybody that's having access issues, you can see that we have people around in industry that can actually help out with that. So we've got, and I'm sure that Blue Earth would be more than happy to get Axeman to anybody that needed it, or we can talk to them about the clinical trials that they're doing. So, don't let anybody say they can't get it. We'll find it for them. Anybody else? I see some new people on. Any other questions or comments for Mr. Smith?
Mr. Smith, how would you rate your plans for your new radio hybrid in terms of having a different efficacy compared to the other PSMA theranostics or diagnostics for that matter? And then is there any potential to put a radioligand on fluciclovine as a theranostic type approach?
So yeah, with RH, there's not, I don't know how it's going to compare. I mean, that's really going to be data that has to be kind of hashed out down the road. All I know is, there is initial data. What we looked at from our Spotlight study, we were looking at verified detection rate as well as the positive predictive value. And it was really just communication with the FDA and what they've had a lot of, they've kind of guided how the study was performed. So eventually down the road, I'm sure there's going to be some kind of comparisons. I don't know if there's ever going to be any kind of head-to-head study. As far as with Axemin, just because of the mechanism of action, unfortunately, because of that, how it gets taken into the cell and then it washes out, to put a therapeutic payload on there, it's not going to localize appropriately. So it would get washed out and you would actually not be able to really treat the cancer appropriately. So yeah, unfortunately with Axemin, using that amino acid pathway is great because it has that upregulation in the prostate cancer cells. But because the cells realize it can't be used, it basically, it wouldn't stay within the cell long enough to deliver that payload.
Thank you.
The where are your, I guess, where are these, how accessible is a Axemin, and what does it take to manufacture it, and where are you manufacturing it, and sort of thing? I mean, what are there licensings available? I mean, how do we help to better get it available to, or make it available to patients and VAs?
Yeah, I mean, it's typically produced at, we have a partnership with PetNet. So most of the PetNet pharmacies readily make Axemin. So as long as they're within, the one thing that's beneficial is by it being fluorinated, you have a little bit more time if delivery is the issue. So you can typically be within a 4-hour delivery radius from a pharmacy to a VA, and that would be appropriate. It's just making sure that it's the VAs have it within their formulary. And, if there is any kind of, if they don't have it, we have multiple teams at Blue Earth that can help with that, as well as, facilitating the education on it. And that's the key thing, is making sure both the referrer and the reader understand the full extent of the disease. Having that communication, as well as having discussions with the patient, helps to know, if you're struggling to find where the disease is, there are tests that can help. And as this field is evolving, there's going to be more material out there. So if a provider's not educated, it's definitely great being a patient advocate and kind of knowing the information that's out there.
Yeah, thanks. Rajiv, I think you had a call?
Yeah, I had a question. Michael, thanks for the talk. I don't know if if you can speak to this, but I think we understand, for PSMA imaging, a PET imaging center typically is suited and has the facility requirements. But how about for PSMA therapy, whether it be your radio hybrid or lutetium, can that be done in a PET imaging center, or does it need a special facility?
So it kind of just depends on the facility. It is, and this is just speaking from experience, it is different compared to the radioligand therapy for neuroendocrine tumors, because that process usually takes a lot longer because you have to deliver amino acids, hydrate the patient, make sure they're not having any kind of carcinoid syndrome. It really depends on the site as far as how they want throughput, because there aren't as many, typically you have to monitor the patients, make sure they have the appropriate blood work, deliver the dose, and then at that point, it's really up to the provider as far as how long they want to monitor the patient. Voiding is the biggest issue. If the patient has to void, there's concern of contamination because that's going to get excreted through the kidneys and bladder. And if you don't have the appropriate flooring, you could be contaminating the room, and then that room may be shut down just because of the radiation exposure to the public. But that's just background info. It really just comes to the site and what they want to have as their protocol for therapeutics. And I can't speak to our kind of what we're doing, just because we're getting things off the ground, and the people at for Pluvicto, they may have other recommendations, but.
Well, that's good. Any other details? Are there, we can ask about these. Are there any things that patients should look out for or should be aware of if they're going through this high or this high intensity imaging and that kind of stuff? Is there any safety issues or things that we should know about or think about?
No, many sites have started to incorporate monitoring radiation exposure. So that's one thing. They've kind of figured out cumulative dose, especially when patients are receiving radiation therapy. But these tests, they typically want to make sure that they're finding disease. So even if they've kind of hit these thresholds, usually, does the benefit outweigh the risk of having a radiation test?
Yeah.
I think when you get to therapeutics, that's a whole different field because they're trying to figure out the dosimetry. With radiation therapy, what's getting delivered to the organs. With radioligand therapy, you're finding out after the fact. So that's one thing that I'm sure down the road there's going to be. I know they're using AI. That's a big discussion point from the imaging community, trying to figure out, can we figure out what we're delivering on the front end? But as of right now, no real concerns. All these imaging agents are very tolerable, and when I was a tech, I've seen patients that had 40 PET scans. So it's really just finding where the disease is, and as long as the patient's willing to go through with it.
Yeah. Good. I appreciate it. I think anything else? Any other questions from anybody? You got the experts on the call here, so the other things come to mind. If not, again, as a reminder, this will be posted on the website, and the briefing that Mr. Smith gave us will be put out there as well. And so, we're keeping up. I know it's an incredibly evolving field with all of the new imaging coming out, and it's just going to continue to evolve. So please encourage anybody that you're talking to that if they're diagnosed, that there's no reason why they shouldn't ask to get a PSMA scan or an Axeman scan if it's not available. I've had both, and they showed very similar results when I had the Axeman and my first gallium scan. So it was very, very similar results. So anybody else, anything else, we'll call it an end, and we'll go to the next month. I appreciate everybody. A lot of things coming up this month, so pay attention, and we appreciate everybody's participation. Thank you, and have a good evening.